Meena Nair to talk on normal tension glaucoma treatment dilemma.
Good morning, everyone. At the onset, I wish to thank KSOS and Dr. Girija for this opportunity. My topic is normal tension glaucoma, a treatment dilemma. Diagnosing and managing NTG is indeed a challenge, especially because IOP is in the lower end of the spectrum. And I feel that unless definite the genes are identified for NTG or the pathophysiology of NTG is better understood, we can still consider NTG as a subset of primary open-angle glaucoma. In the next few minutes, I shall take you through a few case scenarios wherein I'll bring forth the dilemmas encountered in the management of NTG. Here I have a 46-year-old lady who gave typical history of migraine with aura and had paresthesia of her fingers and toes, intolerance to cold, and generalized body ache, which the physician put it as fibromyalgia. Note the right optic disc, which is definitely glaucomatous with the bipolar notch and the bipolar wedge defects, and the left eye with a lesser degree of an inferior notch and a wedge inferotemporal defect with thin central corneal thickness and a day diurnal showing a range of fluctuation of just 10 to 12 millimeters of mercury. So what do you do? Obviously, with such a gross asymmetric advanced glaucoma, you have to treat. So she was started on topical prostaglandin analog, and aiming for a reduction of 30%, and this is evident by the stability in her fields done recently. The fixation threat, the tubular field, right from 2009 to 2022 is maintained in the right eye, and the left eye is absolutely asymmetric. So apart from the routine investigations, I would say that when you have an asymmetric GON, you have to do a thorough cardiology, a thorough neurology, and in her case, a rheumatology to rule out autoimmune etiology also was done. And in the young, I would say a Doppler imaging of the bilateral carotids and the ocular blood flow analysis needs to be done. This was done in her case in both 2009 and 2019, and nothing was detected. This is yet another young man, 40-year-old, but on prostaglandin analog, started from elsewhere since 1 year, now planning to go to Saudi, and came to me asking whether he needs to continue medication lifelong. And a cursory look at the discs, I thought they look more or less symmetric, except for a little tendency to notch superatemporally in the right eye, and he had thick cornea. So I stopped the medication, asked him to come back 2 months later for a 24-hour DVT with 24-hour BP charting, and that was done. And it was within normal limits of just 10 to 14 to 16 millimeters of mercury. So the medication was discontinued, and he's been followed till 2022 last with normal fields. Of course, I would like to emphasize here that when you have this with mild pallor, your OCTs will always, can give you misleading results, and you can think it's a red disease and start treatment. So what do we learn from this? I would emphasize in the management of NTG, the diurnal facing, either office DVT or 24-hour DVT has a major role. Central corneal thickness has to be done in all cases, and in the young, a Doppler scan imaging of the blood vessels. And remember always that you would be looking probably at an IOP, which is in the normal phase of a POAG. And again, when you have asymmetric glaucomatous optic neuropathy with no asymmetry in IOP, always think of other causes. The next is a patient who is in 50s with multiple comorbidities. He had diabetic, he had hypertension, and he had coronary artery disease. And the very discs by the beta zone and by the large deep cups suggest advanced glaucoma, as evidenced by the fields which are impinging fixation, and which by the control of all his systemic morbidities very well, he has been maintaining the same central 10-2 fields 2013 to 17 to 19. And after that, actually, I have been finding some erratic fluctuations in BP, when even a thought of whether he should undergo a TRAV was thought. But a good control of his hypertension and cardiology has resulted in even the recent fields giving a similar field defect. This is an elderly 65-year-old woman who came for an ophthalmic evaluation routine. On examination, I found she has bilateral inferior notch, IOP of 12, facing of 10 to 15 millimeters of mercury, and thin corneas. So because of her inferior notch and typical fields, in NTG, when you have fields deep, steep defects close to fixation in the central 5 to 10 degrees. You have to correlate with the disc with the polar notching. And she was then investigated, thorough cardiology evaluation, and we found that her Holter showed cardiac arrhythmias. She had atrial ectopics and supraventricular ectopics, and the physician had put her on Verapamil 3 times daily, 40 mg, and she has maintained her fields also, as evidenced by the GPA summary, as stable. These are the latest octopus fields done recently because she had some cataract, so doing the Humphrey was difficult, and we see that the 10-2 fields are showing stability without encroaching fixation as she presented initially. So here we learned that control of systemic comorbidities in a case of NTG is very important, especially hypertension control, looking out for other causes, and avoid the nocturnal dips, because you want to have a good you should not have a low ocular perfusion pressure. When the nocturnal dips occur, you have a risk for a reduced ocular perfusion, optic nerve head perfusion rather. Next is a lady who presented, who was in Maldives and was started on travoprost for a year, and she came for the second opinion, and I realized she had disc hemorrhages on treatment, both in the right eye and left eye. You can see the resolving hemorrhage. So I underwent a DVT on treatment and found that it was not acceptable because she had thin corneas as well. So additional medication was started, and she's expected to come for the review after 6 months. The next is a lady who was seen in 2016, had a tilted disc and a baseline field defect. So it was difficult at that point of time to know whether it was a glaucomatous defect or due to tilt, but because the facing was normal, she was observed. But by 2018, she developed a disc hemorrhage in the other eye. So obviously, she was considered as an NTG and started on treatment. And this is the initial field defect when she presented. And by 2020, when we are seeing her, things are okay. In June, by November, she developed a disc hemorrhage at the inferior pole in the right eye, and she had one in the left as well, which took 6 months time to resolve. So when you have normal intraocular pressures, normal facing, and on treatment, but you find hemorrhages, that too you will be bilateral, always consider progression. You can see the right eye is stable, but the left eye shows that the LD has showing a linear regression slope. Now the left-right is normal. So what do you learn from this? You have to consider progression. The risk of progression has to be considered. And how did we manage her? We followed up more closely, but a gonioscopy revealed that she is a must at this stage because she was going in for a combined mechanism glaucoma, and that closure was picked up by a revision gonioscopy. Now, this patient was not treated in 2012 when she presented early because, though it was looking like a disc suspect, but because of the normal intraocular pressures, and he presented in 2017 with a superotemporal branch retinal vein occlusion. But you can see that despite that, the fields have been the same, and the fields are still the same. So not all NTGs need aggressive treatment. You have to identify the progressors. And disc hemorrhage always raises the suspicion of progression. Now, this is a patient who was on PGA analog and on treatment had normal pressures of 8 to 10, but by July 2021, that is 1 year with me, was noted to have had progressed with fields. So what was done? A sleep test was done, and 80% of hypoxia was noted, and the CPAP was started, and with that, we noted a stability in the visual field defect. Here is an asymmetric glaucoma patient. This person came from UAE with this asymmetric damage and had the central steep defect, and the patient was symptomatic and says that he was having progressive disease. All that we did was a cardiology evaluation, a sleep study, and a Doppler, and we noted that he was a known case of obstructive sleep apnea, but a change of the CPAP mask worked wonders, and he retained stability. So vascular factors as a cause for progression have to be thought of. And finally, this case with tilted disc looks more like a disc with a pallor and not really glaucoma. Patient had dyschromatopsia, and you had color vision reduction and contrast sensitivity degrees, was evaluated in neurology, but we had started anti-glaucoma treatment on this myope, and he has retained his field as well, seen recently. So neurological investigations, when do you advise? When in unilateral cases, when the pallor is disproportionate, when the disc does not correlate with field, and visual fields respect the vertical meridian. So from the cases discussed so far, I would like to convey that no clearly defined IOP cuts off. We don't know which IOP will damage the nerve head further. And like in the high tension glaucoma, you cannot expect a dramatic drop in NTG cases. And you have to consider the non-IOP dependent mechanisms as well. The CNTGS study has shown us that lowering IOP is still the proven treatment. You have to reverse the circulatory deficiencies, correct nocturnal dips, use drugs like rimonidine or dorzolamide and bitaxolol as topical agents. And when the on-medical treatment, when it further progresses, consider surgery. But the dilemma remains how much of lower target or IOP you need. Do not go beyond the episkeletal venous pressure. Monitoring is crucial in NTG cases. Identify progressors. And neuroprotection is an interesting area of ongoing research. But mind you, diagnosis and managing NTG, though it requires a lot of persistence and diligence, we can have patients in the future with a well-managed NTG and no progression in fields. Thank you for your patient hearing.
Thank you, Dr.